Thank you, Dr. Wright and Dr. Sidney. Every year, the Sidney Report draws attention to a significant trend that affects cardiovascular health and health equity. The impact of these signature reports is evident in their coverage by the Wall Street Journal and other media. But as we just heard in the discussion with Janet Wright and Steve Sidney, this year's report may be the most significant, and its call to action the most direct and consequential. It sets the stage for our next two panels, and this National Forum annual meetings focus on actions that all of us can and must take to eliminate cardiovascular and other health disparities, to prevent disease and disability, and to achieve health equity. Our first panel will tackle the challenge of helping us visualize a framework for a new U.S. approach to health. I'm pleased to introduce the moderator, Jay Bhatt, a practicing physician, founder and principal of JDB Strategies, ABC News medical contributor, adjunct professor at the University of Illinois Chicago School of Public Health, and member of the National Forum Board of Directors. Jay?
Well, thank you, John, for that kind introduction. It is just an honor to be here with all of you today and with this esteemed panel that I'll introduce in a moment. You know, Steve Sidney points out that in the new National Forum Signature Report that the COVID-19 pandemic has exposed and worsened disparities and inequities in cardiovascular health that have been there for a long time, but have not had the kind of public attention we see and have seen through the pandemic. It has been illuminated in significant ways. Those of us who work towards optimal cardiovascular health for all know that there are multiple causes of health inequities. Certainly variations in healthcare access and quality, social, economic, and environmental factors, systemic and structural issues such as racism, that there also are competing priorities within healthcare delivery systems. And there are challenges based on resources, areas of focus, and just trying to bring everyone together on the same page across a journey. People are at different places in their journey on the issue of health inequities. But we also know that it is broader than just race and ethnicity, although very important. Race and ethnicity, along with gender, along with place-based inequities, along with people who have disabilities, along with veterans, are all areas to consider. Recently, a medical group I talked about raising hypertension control rates in a population which is less than 40%. And this group, medical group, said that they weren't interested because they're not penalized for being less than 40%, and there's no financial incentive to raise their control rate. So incentives play a role in the mindset of folks as well. Today's panel will sketch a framework for a post-pandemic environment that prioritizes health equity and invests where it matters to eliminate inequities and improve cardiovascular health for people throughout society. And joining me today are Elizabeth Betsy Bradley, the 11th president of VASSAR College and co-author of the wonderful text and book, The American Healthcare Paradox. I'm joined also by Mike Cropp. Dr. Mike Cropp is a family physician, CEO of Independent Health, and a board member of AHIP and the Alliance of Community Health Plans and the National Forum. And we're also joined by Margaret Sabin, past president of Children's Hospital of Colorado, Colorado Springs, and former CEO of Penrose St. Francis's Health System. And we know that the Sidney Report recommends strategies and actions to raise the priority on COVID-19 cardiovascular disease prevention, use physical activity to protect people from COVID-19 cardiometabolic disease, and increase certainly our COVID-19 vaccination rate. So to begin our conversation about the new environment, let's start by asking Betsy Bradley to answer a question that's vexed people in public health and others for many years. How do countries that spend half as much on healthcare outperform the United States? How do they spend less and yet have longer lifespans, lower maternal mortality, et cetera, when we look at other measures? So Betsy, I'll turn it over to you to kick us off.
Thank you, Jay, and thanks so much for having me on this panel. I'm delighted to be here with these esteemed colleagues. Well, this is the question. I think people usually ask it as, how are we spending so much and getting so little? And maybe we just get some facts out on the table. We're now spending about $10,000 or more dollars per capita on medical care every single year in the United States. And even when we adjust for price parity, really the rest of the high income countries in the globe are spending about half that on their medical care. But when we look at our outcomes, it is important to acknowledge we have some outcomes that outdo everybody, like the speed of getting an MRI. You want an MRI, you're going to get it in the United States, and you'll get it fast, probably the same week it's ordered. Knee replacements. We do more knee replacements than any other country in the world. Or kidney transplants. We're really successful at it. If you need to have your kidney transplants, have it in the US. You will have less morbidity and you will live longer based on the great technical medical care we give. The problem is there are thousands of other, as you just pointed out, Jay, outcomes that we do much worse. Like our maternal mortality rate is 6 times that of Sweden. We have lower life expectancy, higher infant mortality, more heart disease, more obesity, more disability, more lung disease, more HIV. It goes on and on. Anything that is a determinant or a outcome that is really about the health of our population, we're doing worse. So why is that? Well, there are a couple other facts we have to look at when we try to understand why we get certain outcomes in health. And the big fact is, first of all, what are we spending in public health? That's important. And then what are we spending in the social sides of health, like housing, food, education, parks, recreation, proper security systems, all of those put together. Well, public health in the United States, we only spend $275 per capita per year, even in COVID. With $10,000 for medical care, $275 for public health. That is just no way to run a system. But then it kind of gets worse, because if we look at, for instance, an intervention like safe housing, we spend less than 1% of our GDP on safe housing for people who are otherwise homeless. And there are so many clear studies that if you house people, they're less likely to eat up medical care resources in the emergency room. And that's just one. There's food insecurity and all kinds of educational interventions, et cetera. They're often at the community level. And if we look at these other countries that do well, guess what? They spend a lot more than we do, sometimes double what we do on those social services. So when you put all these countries together, we kind of spend the same amount of our overall economy on these factors that make us healthy, but our portfolio mix is heavily skewed towards medical care, and their portfolio mix is heavily skewed towards social services, and it makes a difference.
Betsy, I think what's striking to me is this mismatch we have right around medical versus social spending, or spending on the things we know translate to better health. And other OECD countries investing $2 in socioeconomic factors for every $1 spent on healthcare, but the U.S. is flipped and invests only 55 cents on some of these factors for each dollar spent on healthcare. So let me come to you, Dr. Cropp. As we think about what are the ingredients that it'll take for us to get to better health for all, we might think about the notion that Betsy just suggested is about kind of an upstream approach that helps communities thrive. Could you talk a little bit about what you see as the path forward in terms of macro changes and where our country should invest and change incentives?
Let me touch upon a couple of key areas. I think you mentioned something, Jay, early on, and that is incentives, how we pay within healthcare. We made a deliberate movement, started 20 years ago, to pay for quality and incentivize the right things. And that movement has continued for us. And what's been exciting is, as we see physicians focusing more on population health and being rewarded for better control of diabetes and hypertension, et cetera, they're asking the question, well, what can be done for our patients? Because some of them are challenged by their circumstances. And so that's brought us to think about the investments that we need to make for individuals and for communities to help the patients have better access to the things that are going to help them in their lives. And so we've done things like make investments in creating a 501c3 organization that's created safe bicycling across the community. starting in the inner city areas with safe routes to school for kids to promote healthier physical activity for those populations. We're now working with community gardens and distribution of fresh fruits and vegetables through the various programs that we have through the foundation that we have started. And we're using digital technology now to provide timely information to people to be able to help them make better decisions with respect to their diet and their activity in the moment that they need the help. So when I think about the things that need to be done, I think clearly within the healthcare system, we've got to repurpose some of the dollars, more of it up front, incentivizing the right things, less of it at the back end. We need new care models there as well. But there's a lesson here in Buffalo that I just think is so powerful. And it relates back to the pandemic and Dr. Sidney's report, that early in the pandemic, we saw mortality amongst the Blacks that was 2.5 times their representation in the population. And very quickly, community resources mobilized to do 3 things: to get more testing available in the Black community, to get more personal protective equipment available in the Black community, and to get more messaging out through trusted community resources to reach these people, to let them know what was available and what they should do. Within 6 weeks, the mortality rate dropped back to the level of representation of the Blacks in our community. And for me, that lesson is huge in terms of when we start to now think about health and start to think about reaching populations that have been inaccessible, the health system has been inaccessible for them. We have to reach out through community resources that know these people and are trusted by these people. And I think we can take this lesson from the pandemic and now think about how do we engage these people in reaching folks to help them better understand what they can do for their own health to minimize their risk factors of heart disease, stroke, and these other conditions. So I'm really excited about what this lesson really portends in terms of possibilities of repurposing dollars and repurposing work in the communities to be able to get at some of these disparities.
Yeah, and Dr. Cropp, that's a wonderful example. And we'll come back to you on this question of, and to the panel about, who plays that role. There's been discussions about different stakeholders with the healthcare delivery system. Well, it's not my role. It should be the community-based organization's role, or it should be another organization's role. But if we're going to make progress on health for all, how do we need to align the roles of the various stakeholders? And so you've been certainly a physician health plan CEO, and now we'll get really the perspective from Margaret Sabin, who is the hospital CEO and a longtime advocate for population health. What needs to change to prioritize population health, but where does the opposition come from to try to drive forward the mission of the healthcare organization and your vision? Sometimes that can come from various places, including within.
I think there's a couple things here, and I think both Elizabeth and Michael touched on both of them. And so, the current system is incentivized to be a rescue system totally. It's very difficult to break out of that rubric. And each year we look at what did we do last year? What can we predict this year? Because, we can predict sickness. Never mind 75% of it's preventable, as certified by bodies such as the American Cardiovascular Society. We go on and on. We all would agree it's 75% preventable, but we predict that we'll get the same as we had last year or more. We build our beds that way, our ORs, we buy MRIs. And yes, Betsy's right. We're blessed with a lot of MRIs. In looking at what we're doing, we've got to really be honest about the term upstream. Upstream isn't just managing the health of an individual with type 1 or type 2 diabetes. Upstream is identifying the risk factors. It's when that 11-year-old child has metabolic disease and has a horrible diet and is sedentary. we know that leads to type 2 diabetes. We know it's preventable. Once the kid has it, it's a noose around their neck for life. We are a society that could prevent it. Are we good enough? Are we big enough? But as Michael said, those factors that help prevent that are in the community. It's the schools, the churches, the playgrounds, the employers. So the healthcare system, it can be a stakeholder at the table, but it is not the entity to create that safety net, because that safety net lives in the community. So we've got to believe in prevention and stop using prevention for what is early treatment. Early treatment is important. The healthcare system pays for it, not as well as later treatment. You know, much rather, you know, in terms of pure reimbursement, see a heart surgery as opposed to a doctor's office visit of, okay, lose 20 pounds, start walking, eat a reasonable diet, which might have prevented the heart attack, but we pay a lot for the heart attack when it happens. Betsy's right. There are things we do really, really well. You come into our ORs and you get our symphony, and we are at our best. You may never know it, but where we really as humanity need to be at our best is when the risk factors are producing, because we can prevent tragic disease and we can prevent the rescue system. And if we do that, it's absolutely that shifting of resources. And I think the last thing I would say is we have to stop hiding behind, well, we don't get reimbursed to do it. We are a powerful stakeholder as the healthcare system. We need to be at the table, providing that early evidence along with other partners and philanthropic resources, which are flowing in the system now, to prove scientifically that prevention works. If we believe it as a country, I have to believe we'll fund it more, because we are scientifically based as a nation.
So yeah, I really resonate with that perspective, and the way you defined upstream was really helpful as in how we should think about it. Now, you know, I might come to Betsy and say, what do you make of the perspective that you just heard from your colleagues on the panel? You know, how do we make this transition for those that are comfortable with the status quo of where we are, to try to get to, you know, that place that they both just talked about?
I really agree with what both of our colleagues have said. The only thing I would maybe slight amendment to what Margaret just said is, I think the medical care system still has an incredibly important role. We don't have enough primary care physicians. Primary care physicians are the hinge between a medical system and what you're doing at home. And I think you would probably agree with that, Margaret, that piece of it, that, and the pediatricians and the OBGYNs, the people who see people who are healthy, are the hinge when they start to see these risk factors, which I think Margaret has identified so beautifully. So I think their seat at the table is tremendously important. You know, often after our research, people have asked, well, if we invest in housing and Meals on Wheels and early childhood education, are we going to see an offset in medical care? And of course, our work was always unable to do a randomized trial like that. But I fear that, in fact, we see it in individual studies. There are dozens of studies that show cost effectiveness of investing in social services, but that's different than having an entire country reduce its medical care spending. And I think to do that, it is not a technical problem. It is a political and economic problem. So if we were to reduce our healthcare spending, we would need to deal with pricing, with the lobbies, with the fact that it's 19% of our GDP, so practically everybody's employed and profiting off it. You know, these are such tricky pieces that we've embedded in our medical care system. I think we can spend the same and get a lot better outcomes, but I have yet to see a state that actually has been able to cut their medical care spending. People will be just as well without it, but nonetheless, it does bring some profit to a lot of people in the country.
Yeah, I think, you know, one of the things that we've been talking about locally, and I believe a lot of this is going to have to start locally, because it's just so hard to change that massive health industrial complex. You know, we've seen grotesque examples in pharma, you know, with medications that used to cost $2 now costing $2,000 with no new science behind that. But another story for another day. You know, what we have started to talk about locally with employers to begin to get them to understand that there's simple things that they can do to change the environment and the culture that their associates spend a decent amount of time in. And when we talk about the rate of growth of healthcare at 5 to 6% per year, crowding out pay raises, crowding out social investment, crowding out other goods. But we just can't point that out alone. We also have to point out things that we know through the literature that are relatively minor investments that can make a difference. And beginning to see some of that take root, now you're beginning to get employers that are making some of the smarter investments in promoting the health of their associates. And then you're getting some employers who recognize that they have a responsibility that's bigger than just their employees, because others in the community might be their employees next month, next year, whatever. And so making the prudent investments in the community resources to build better infrastructure for physical health and other community resources that are going to make a difference. And so that's part of the excitement that we're beginning to see take root in our community.
I think we have an opportunity, Jay. I think we have an opportunity post-COVID. So how did we deal with COVID? How did we get groups to second vaccinate or first vaccinate in the neighborhoods? It was neighbors talking to neighbors. It did not come from the healthcare system. There wasn't trust there. So, I call upon this opportunity of time, mayors, governors, school system leaders, public health school leaders, and our healthcare system to come together with all these funds coming in, much of it designated to mental health, but mental health is part of physical health. It's all part of social determinants. Come together and create a community rubric. No one, as Michael and Betsy has eloquently said, and they've published, no one entity can change the healthcare system. No one. But if we come together, we can transform and put our resources together. If those entities come together and begin to look at a rubric, a true safety net, not a safety net for acute care, we have that. A safety net for all forms of care. We have the opportunity right now in the wake of COVID and the devastation that's left in terms of mental health in our country. 1 out of 3 kids, the last UNICEF report, is struggling with behavioral health. Okay, last time I checked, that's 1 out of 3 struggling with behavioral health, but they're 100% of our future. Come on. So if we seize that opportunity, and I couldn't agree more, Betsy, on primary care. You're absolutely right. That's that first rung we need to have. If we strengthen that whole rung and include the FQHCs in our communities, we've got a start of something that can absolutely transform. And by the way, you're right. And that should inform policy and set us on a path where we can begin to look at health as it's not rescue. It's about how we live, how we love, how we play, how we learn, and how we labor.
Yeah, Margaret, I think what you're also suggesting is a fundamental reframing of how this country thinks about health, as Betsy and Dr. Cropp also suggested. And one of the things I think about, in addition to what you're suggesting here, is also this issue of affordability, which we struggle with. And how do we take costs out of the system and create less out-of-pocket spend for the consumers? I think that is one of these big issues that our nation's facing.
Yeah. There's another dimension here that I'd like to bring up, Jay. Right now, I think there are plenty of lessons that have come through COVID and lessons that preceded COVID that demonstrate that simple investments in health actually have a significant return on that investment. And so many of us have been sort of pushing the population health and the public health view like that Sisyphus, rock up the hill to get people to buy into it. Now, I think that there's a building case for the economics of creating health, and that the costs of poor health are a significant drain. And it's not just on the 5 to 6% annual trend we're seeing an increase in healthcare spend, but it's huge in terms of absenteeism and lack of presenteeism that's costing us whether it's an industry, whether it's, a regional economy. And part of this is the behavioral health that Margaret's referring to. Part of it's the physical health. But there is a growing body of evidence that says the costs of poor health are huge. And it might be that, we can no longer afford to just talk about population health and disparities and public health through the lens of that scientific, but we also have to build that connection to the costs of poor health to get more people's attention to make the right investments going forward.
And what do you, oh, go ahead, sorry.
Yeah, I just had a thought on this that I don't think we've talked about very much yet, and I'm really interested in Michael's view of this, but we don't have place-based insurance at all. I mean, we insure an employer has people strewn everywhere. So I always found that in our research, it was hard to get employers excited about making place-based investments like, jungle gyms and safe lighting at night and education in the school system, even if it would save them money for people who they insured, because their people are strewn throughout the country. If they're a large employer, we never get that motivation. And it's radical to say place-based insurance as opposed to employer-based insurance, completely radical. But there are experiments in that I think could make a big difference. I also think it returns a lot to the consumer, because the consumers are all living in the same place with the same insurance. There's a certain amount of working together and possibly returning money to consumers. So I just put that on the table, since why not think of new ideas sometimes?
I love that thought. And I'm going to put something out there that's perhaps out there.
Great.
But the last administration, didn't do a heck of a lot good in the healthcare space. But there's one thing that I think opens the door to something that you're getting at. And that is the regulation that allowed for employers to contribute to a health reimbursement account.
Yes.
And so large employers could think about fixing their outlay for their employees in terms of healthcare costs and donate to a health reimbursement account, and then let them go shop on a local exchange.
Yep.
And now healthcare becomes more local.
Yeah.
And you can think about that in a totally different way. And you're not beholden to a very finite set of insurers and employers that are, geography dispersed. And it creates a whole new dynamic in terms of the community and the commitment to one another. But could be just a pipe dream.
I like that, and it creates access. But if we don't change access to what, and the impression of you can get anything, you can get an MRI in 3 minutes, maybe you didn't need it, but you got it anyway. And take away the personal accountability for a healthy lifestyle, because we're very, very clear. I mean, one of the biggest things in COVID, if you had a healthy lifestyle, you had greater chances of living. That's not front page news. It's not. Instead, it's a fear-based reaction. If we can't change our culture on this, then I don't think we'll get what all of us see as a vision of a healthier community at an affordable cost.
Can I just take us back to something that Betsy said earlier, and you reinforced, and that's the primary care point. Because when I was in primary care practicing, one of the things that we did back in the mid 1980s was create a same-day access appointment scheduling system. So people could be seen when they needed to be seen. And the power of that was unbelievable in terms of people not insisting on all the technology, not insisting on all the antibiotics, not insisting on the specialty referrals, if they knew that they could come in and see you when they needed to.
Makes all the sense in the world.
It was enormous. And now we're getting back to that here in terms of some of the transformation that we're doing with primary care, so that it's not only a value-based payment model, which rewards them greatly for results, but it has them transforming their work to be much more patient-centered and to deal with the diverse issues that people cross the threshold with, and not just think about that prescription or that referral or that next high-end imaging. piece.
Let me come back to Dr. Bradley for a comment you made earlier around both the issue of housing and other social factors. Dr. Bradley, the point I was going to share is that housing is health, right? On average, those with unstable housing have 27 years less life expectancy than
Yes.
those that don't. And so, how do we help organizations and the health system, whether we think about both commercial and government payers, think about structuring value-based care in a way that helps folks make those investments? And to the point of, all right, Margaret's idea of bringing the stakeholders together, that may be also a way to intersperse value-based care and the right investments.
Yeah, in some of our case studies that we did, there were hospital systems that were investing in housing for this very reason. They anticipated value-based purchasing by Medicaid coming up in the years ahead, and they thought, we better be there. We ought to be able to actually put these patients who would otherwise, frankly, take up beds in kind of languishing as really needing housing. So they built housing and moved people out into the housing. It was really good for those people. But one of the unintended effects was it emptied beds, which they could fill with cardiothoracic surgery, which was very expensive. So it's a really tricky thing to figure out how to do value-based purchasing in a part of the system when other pieces of the system still are ostensibly fee-for-service or still are basically, you did a cardiothoracic surgery, you're going to make a lot more money. And I think Margaret said something really interesting as we were preparing, and I think at the beginning of our time, that, hospitals' agenda, their survival depends on them filling the beds. And then filling the beds with things that reimburse more, that even gets them more. So it's hard for us to ask them to be different on that. It's hard to really figure that out. And value-based purchasing, so much has been tried. I think some of it has been, and probably Dr. Cropp knows the most about this, but some of it has been successful, I think. Some of it, like water flowing downhill, hospitals and physicians figure out how to get around that rock and still get down the hill. But, I do think there is some hope, and wonder what others think about that.
Margaret, do you want to take a run at that?
Yeah, that's absolutely correct. But you know what? Across the board, 20% less beds, I bet we wouldn't see a tick in our mortality. Not a tick.
I agree.
Particularly when so many, you know that.
It might
from
be
your
better.
research. Yeah,
it might be better
better.
because the moral hazard goes down. You're so afraid there are no beds, you're going to take care of yourself. Yeah.
Exactly. And
Yeah.
then if that were done, and maybe there were, I'll show my age here, but I'm a fan of parts of capitation. If an organization that created more health in the community could have more capitated lives, ergo more market share, it's being rewarded for being a good community partner. Let that form of capitalism play in the community, but not this, leash and chain tied to, the rescue care side. And that might be a way to slowly begin to change.
Absolutely. I think that the accountability that comes within a model like the Medicare Advantage program, it is bringing about investments from places you wouldn't necessarily expect. There are some of the national for-profit plans are investing in housing.
Yeah.
For just these reasons. And so I think that, the right kind of economic accountability models drive a lot of this and bring about the innovation that.
But you have to take the beds out, though. They build the housing so they can fill the bed with something more expensive. The bed's got to come out. And that's where, it's hard for communities to agree, take out beds.
I agree.
It's the beds. And it's also, it's interesting, the missed opportunity that we had with the Affordable Care Act to redirect some of the post-medical school education dollars away from high-end specialties into primary care specialties, because as much as the beds are the issue, the supply of some of the high-end specialties are big issues as well.
Agree, completely agree.
Yeah.
So great conversation. I wanted to also pick up on this notion of innovation, Mike, that you just talked about and have alluded to by Margaret and Dr. Bradley. It's also the consistency and approach that you. So at Medical Home Network, where I work, which is a Medicaid ACO convening FQHCs, it's delegated care management at the practice level. It's consistent, highly reliable workflows, prioritization of tasks. It's the tech-enabled care. So the data is there for the right place at the right time to make the right interventions. All of that coming together has led, ultimately to better outcomes and 100 million in shared savings over the course of 5 years that get reinvested back. So this also questions, some say the safety net can't do this, community health centers can't do this. It is certainly possible if you have the right kind of care and system in place. And I also think that it takes trust, which Margaret, you alluded to earlier, so this question of, I think, how we're going to transform the system, trust is also an important part of that. And there's been important conversations there. So maybe I'll start with Margaret and say, could you talk a little bit more about how do we strengthen and sustain trust between those populations that we're caring for and the health system? Because cardiovascular health and stroke prevention, requires being upstream, like you talked about.
Yep.
And trust is, I think, an important part of that.
I think that is such a good question. And I remember years ago, we did a form of a Framingham analysis in a large community. And the first question the neighbors said when the hospital provided lifestyle coaching at philanthropically funded, not at a cost, was what's in this for the hospital? And I don't blame them for asking. I don't. And it wasn't until neighbors went to neighbors and said, wow, I've changed my life. I've done this. So I think the trust is more to whom are we serving? And if we're serving an end that, back to Betsy's comment, puts, more heads in beds, that's not going to feel real good to a community. If we're serving a true mission for that community to be healthier, and we're measuring it, and we're going to share that with authentic community engagement, authentic meaning we come back to the community and we show what we did. Maybe we failed. We share that. Trust is about understanding that you're open to failure and success. And if we get to that level of sharing, we will get some engagement where there's informal community leaders. I feel like there's like a sort of a mayor of every big neighborhood, everyone knows who he is. It's John on the corner, and you want something done, you go to John on the corner. We need John on the corner to believe in our healthcare system.
Right. Well said. Betsy or Mike, anything else you want to add to that thread of conversation?
I think you are just so spot on, exactly what you said. I was just going to add the issue of sort of let it take time, because the trust building is so hard and you can lose it in a heartbeat, no pun, even though it takes years to get together, you lose it. And I think the diligent, just going back, showing up and showing up and showing up and showing up is also part, in addition to everything Margaret said. It's hard, but it, I think, really can pay back.
I think as we thought about this, we thought about sort of that last mile of connectivity, to use a technology sort of example. And what's the better path? Is it better to work through the trusted community resources that already exist in the churches and in the block clubs and the other groups, and bring them a basic set of skills, rather than for the system to try and reach out and forge those connections? And our belief is that the former is far more effective than the latter. And so recognizing what are some of the really important skills that we can bring to those community resources that already have those relationships to help us better understand who is at risk, who has those risk factors, and what do they need that can be brought to them through the lens of how they live their lives. Because I think when we look at this inside out from the health system perspective, we miss the mark most of the time. And so I think it is easier to train at the trusted end than it is to go out and build that trust over time.
Right.
I was just going to add that we don't trust our healthcare providers, and there's a lot of issues there, but I think also people don't really trust their cities and counties and governments that are creating housing projects and, food courts supposedly and all kinds of social services. There's a lot of problems there too. And I often wonder, how do we really create trust writ large where it is going to be John on the block for sure. But what can the government do to enable a situation where data are more transparent? Because often if you have transparent data, and if you ever try to find out like how many housing days have we paid for, forget it. Social services, you try to count the social services a county is paying for, it is very, very tough. So that whole sector lacks a lot of transparency and has tons of politics. So I think we have another trust issue there for communities to trust the governmental agencies that are providing them the social services they need.
And the data shows, right, that also both economic inequities have cost the country more than 250 billion, and if we were to make a dent in that, that's not only the right thing to do to turn the tide on health inequities, but it's the smart thing to do. So there's an economic imperative, and that equity and quality are both sides of the same coin. You can't get to quality or not moving the dial on equity. And so what other sectors can play a role in bringing about the change? What roles does the business sector have? Dr. Bradley just spoke about the government and the relationship there with various stakeholders around trust, but they certainly play a role, and how might other sectors play a role, including those with lived experience, which are the people that are impacted by the services and the change.
Well, I think that businesses need to sort of they live in economic worlds. They think in economic terms. Being able to show them, what the costs of poor health are for their workforce and for their community, it's pretty powerful. I was part of some work that was done in Nashville to look across the community, to look at what the costs of poor health were costing the community overall, and what that looked like relative to other communities that they were competing for business against. And once they saw this is a problem, they mobilized. But you have to put it in terms that they live with and they work with on a daily basis. And as you said, Jay, the economic case for poor health is really beginning to be really quite strong. But it's just a challenge in terms of how do we frame that for individual businesses and for chambers in ways that they can see that as a problem. And part of that has to be, you can't just put the problem in front of them without offering some practical solutions that are within reach too. So you've got to work both sides of that.
Margaret, were you going to jump in here?
I just wanted to mention, we actually have something that has happened in the last 6 months, but everyone think for a minute, what's the one new senior level position you're seeing added across the board everywhere? Help me. A senior vice president of diversity, equity, and inclusion.
Right.
Guess what? That's not in Cherry Hills. That's not in the top suburb of LA. It's in our suburbs that have needs in social and economic determinants of health. We have this opportunity. We have funding coming in, and those folks are realizing, and I hats off to them, that when you go in with a light footstep. You learn culture, because those people, some of those kiddos, they're more resilient than they're more benefited, at least economically, counterparts because of what they've had to live through. Doesn't mean they're happier, doesn't mean they're healthier, but they're resilient. And a resilient child, you don't tell them what to do. They find the strength within and they help, and you work with them on coping skills. So on that little piece, spread it to the healthcare system, a navigator to the local FQHCs, the Medicaid programs that Dr. Cropp talked about. I love the expansion of Medicaid. And by the way, last administration did bring us that. So when you said they didn't bring us much, I actually think there's more than we can imagine. Plus my daughter's still on health insurance because of that. But if we think of these things, that's why I think this post-COVID, Jay, we have such an opportunity in front of us. I really believe we do.
Yeah, you're spot on about that. I think this is just a tremendous window of opportunity, and taking advantage of, the confidence and strength that various stakeholders and the healthcare system has built through COVID. I mean, we innovated
Yes.
so quickly,
Yep.
and folks did innovate in ways they never thought they could, or even took that leap. That's just confidence for further innovation. And the American Rescue Plan and various other investments that have come forth here in the last 6 months. Those are opportunities to invest those dollars. And let's talk about metrics too. Is it healthy days? Is it, closing the gap in certain areas? What are the metrics that are going to show us that we're successful? And so here we got a few minutes here. So I want to come back to all of you for kind of final comments. But the other point I want to make before we do that is that there's a lot of conversation I hear in the ecosystem about the notion of going to a new normal. My view on that is that that's the wrong frame, because the normal didn't work for everyone. And so
Right.
how do we think about a new paradigm, and that paradigm that helps us reimagine towards a new system? And so maybe I'll start with you, Dr. Bradley. What's your takeaway on some of the lessons, and what are maybe a couple of things we need to do moving forward?
Well, I agree with what you just said. A new paradigm for sure, not a new normal. One thing we haven't talked that much about that I think is paramount and kind of goes with what other people have said is tech. Young people love tech. I live on a college campus and I just see the miracles they work with tech. And in COVID, there was so much technologic advance, as you just said, Jay. I think we have
Yeah.
really, really hope there. If we could ever have the social systems talk to the community systems, talk to the healthcare systems, have one, medical record, so to speak, but it went across, that would be amazing. And if we had access to our healthcare providers through tech better, I think it could really do us great service.
Well said. Thank you. And Dr. Cropp, your point of view here to close?
I love where Betsy's taken us in terms of tech. We have seen some incredible improvements across the community with use of tech. We have this tool that we use for diabetics that is a 24/7 Bhatt case manager. And it's been wonderful for individuals to access and help them make better decisions, but it's also been a tool that brought groups together. Athletic trainers using sort of the group function within this to get people to support one another and to build on that capacity. So I'm really excited about what technology can do to help enable individuals to make and sustain better decisions.
Great. And thank you, Margaret.
There is no new normal. In fact, thinking it is just so 2000. Let's go for the new. Let's make this a community partnership, and let's take healthcare to John on the block, and let's start rethinking. We'll never have an opportunity as fertile as now. Let's do it.
Fantastic. Well, that's a wonderful place to end. Thank you so much for your leadership, your tremendous contributions in the field, and for this conversation. I think we've left the audience with some things to think about, this idea that that we've got to have a new paradigm, and that it's going to take partnership, and that we can visualize a way in which our country spends more upstream, so we spend less on acute care and move towards better health for all. And we must all work together to drive that new paradigm forward. So thanks so much again for this wonderful conversation and for the leadership of the National Forum.
Thank you.
Thank you.